This lecture is going to cover the HEENT exam for your pediatric patient. Overall, the first thing you're going to notice is when you're talking to a patient, when they come in, you can do a lot of this general inspection at that point. So we should be looking at their appearance. Do they have an odor to them? What's their activity level? Are they interacting with you as the doctor? Are they interacting with their parents or siblings, the toys in your office? On our physical exam forms, you're going to see there's actually check boxes for some of these. So if the child was alert while they were in there, if they cooperated with you, maybe the child was really fussy and didn't want to do anything because it was nap time. I always document things like that. If mom or dad report that, this is normally their time to nap and they're in their office and you're not getting a lot of great results with your exam findings, or they're just crying the whole time, I always document what that case might be. And so in that case, I would have put, baby was fussy during today's visit due to this being their normal nap time. So these are some just general inspection and general observation things to note on your exam. We're going to start evaluating with the head. We're going to start kind of top down and work our way down the rest of the body. So with the head, on infants, one of the things we're going to evaluate with them is what we call the fontanelle. You'll see on the next slide a diagram of what these fontanelles look like, but we're really going to focus on the anterior and the posterior. The anterior fontanelle is probably the more common one that you think of when you hear maybe soft spot on a baby's head. That's what this is. So it's where the sutures and the cranium aren't always fused together at birth. That allows for the cranial bones to, overlap as they come through the birth canal, and then they open back up again. So with that anterior fontanelle, this is located along the junction of the coronal and the sagittal suture. This is the largest one, and it closes anywhere between 4 and 26 months. Mean age for this is about 13.8 months. So you're going to often find it on your young infants and even up into age 1, maybe even age 2 with them. But all you're going to do is to palpate this is you're just going to run your hand over the top of their head. So I don't ever poke down in it or anything like that, but you're just feeling for where it's at. And I don't sit there with a tape measure and try to measure it, but I often use like my finger width to help me decide how wide it is or if it's starting to close. I kind of use that as my measurement on the child. The posterior fontanelle is one in the back. It's going to be at the junction between the sagittal and the lambdoid suture in the back. This one closes a lot earlier and it's a lot smaller than your anterior. So it's going to close about 2 months. So if you're not seeing any of these young infants or newborns, you're probably not going to feel an open posterior fontanelle. One of the things to note when you are palpating is if the fontanelle is bulging or it's sunken down or depressed. If the fontanelle is bulging, this can be an indication of something a little more extreme that we need to have looked at. And so this could be some kind of increase in intracranial pressure. So we want to make sure that that's looked at. Now this is different than if you see pulsating from that. It's not uncommon to be able to see or even feel like the baby's heart rate through that, so don't freak out if you do see that. But what we want to make sure is that it's not bulging up over the skull itself. That would be a red flag. Depression of the fontanelle you might find a little bit more common in your office. What happens with this is you run your hand over the anterior fontanelle. What you'll feel is it kind of sinks down. Often with this, it's a case of dehydration. So, if it is extreme or it's been there a while, you may want to have the baby evaluated by the pediatrician to see if maybe they need some IV fluids or something else is going on with the baby. But for the most part, a sunken, depressed fontanelle is mostly for dehydration. This is the diagram I was referencing in the last slide. So you can see where the anterior and posterior fontanelles are on the baby's skull. Just a little bit more about the head. So, when we're evaluating the child or the infant, one of the things we want to look at is we're just going to observe and look at the head and the cranium. We want to make sure that there's no bumps or asymmetries noted. That's going to be really important to look at. The shape of the head can give you a little bit of insight about maybe how babies came into this world, or maybe they've got a flattening of the occiput, which we'll talk about in a minute. Maybe they're spending too much time on their in the supine position, or maybe they've got a torticollis. It's causing some issues with cranial shape. So these are all things that we want to make sure that we're evaluating on our babies. You can also palpate the sutures. We want to make sure that they're not overlapped, there's no pain or discomfort with those. And so those would be some things to really palpate on the infant or child's head. You're also going to look at their hair and their eyebrows and make sure there's no other abnormalities going on with how their hair is growing in that case. Just some head shape things. So as I referenced in the last slide, talking about flattening of the occiput. So plagiocephaly is the term that we use when we talk about occipital flattening on the skull. Usually this is on one side versus the other, and often related to supine position. We're going to get into more in-depth discussion about plagiocephaly later in the trimester, so I'm not going to spend a lot of time on what we do with that or anything else, but I just want you on physical exam to be able to evaluate the skull and to see if there's any changes in the cranium itself. So that's what a plagiocephaly would be. Another one you might see is what they call scapulocephaly. This is when the head kind of takes a really narrow, elongated appearance, and this is where they've got flattening of the temporal and parietal bones of the head. And so cases where you might find this is maybe in a premature baby where they're spending a lot of time in a certain position. Maybe they have to lay on their sides for most of the day, and so they're getting some abnormal head shape with that. What's really interesting is that if you talk to some NICU docs or even parents that have gone through and had experience with their baby being in a NICU presentation, is that the PTs and OTs are starting to implement where they come in a few times during their day and actually reposition the baby's head to help prevent some of this. So at least they're starting to do some preventative measures in the NICU to help with head shape and position with baby while they're in there. I'm going to go over a few terms with you related to head shape and different issues related to the cranium and the scalp. The first one is what we call a cephalohematoma. What this is this is often caused by birth trauma, whether it be from forceps delivery or vacuum extraction. What happens with this, and you can see in that picture, what they'll have is they'll have a little bit of blood underneath their scalp. So it feels like a sack of water underneath their scalp. Often this will heal on its own within a week or two, but it's most commonly caused by vacuum extraction during the birth process. Caput succedaneum is a really fancy word for a normal, like cone-shaped appearance from baby going through the birth canal. This is a natural result that can happen, especially if baby's in a strange position during delivery. Maybe they're not quite head down or occiput anterior. They might have some head shape issues. Also, if they spend a decent amount of time in the birth canal, it can cause some of this lengthening of the head. And it's going to last a couple days, but it should return back to normal as baby goes through that first week or so. Craniosynostosis is the premature fusion of one or more of the sutures in the cranial bones. We're going to get into a lot more talk about this condition when we talk about plagiocephaly later as well. But the sutures in baby's cranium should not be fused at this point. So if that happens, one of the things that we want to make sure is that we do refer them out. If we suspect that there is a fusion of the suture, we need to refer them out because what happens is if that suture remains, it doesn't allow room for the brain to grow properly. And so you may see some developmental delays with that. And so we want to make sure that the baby's taken care of. So often, as far as treatment goes, this is surgery to separate those fused bones. So we want to make sure that they're getting the proper care with that. What you might feel with this is because the most common site of the fusion is at the sagittal suture, is they may not have a soft spot right at birth, in which they should have at birth. So that would be another clue for that. But we're going to get into more in-depth discussion about craniosynostosis, but I just wanted you to be aware of what the term was and that it may show some changes in baby's appearance and their head shape at birth. I want to go over a couple terms that you may not come in contact with in your pediatric practice, but if you're going to see premature babies or newborn babies, this may come up. Craniotabes is what the term for softening of the skull bones. Most of the time, this is with some kind of congenital rickets or osteogenesis imperfecta, real common with premature babies. If it's just present because they're premature and there's no other underlying condition, there may not be any treatment or any other issue that goes along with this. But I do want you to be aware of that term. And if you are palpating a baby and you apply a little bit of pressure, I know this is going to sound really gross, but if you've ever had a ping pong ball in your hand and you put your thumb into it, this is what I'm kind of referring to when I put the pressure of the skull makes a sound crack like a ping pong ball. It's like when you press into the ping pong ball, that's what this is referencing. So hopefully you won't ever come across this in practice, but if you do, it's just a term for softening of the skull itself. The other one I want you to be aware of is McEwen sign. This has a cracked pot sound if you percuss the cranium. Percussing the cranium isn't a typical exam procedure that we would do, but there might be some cases where you may consider it. So we've already talked about measuring head circumference, and if we find an increase in that, it might indicate hydrocephalus or something like that. This sign is often used to diagnose hydrocephalus, and so those would be some findings. So let's say your head circumference increases quite a bit from what is normal for this baby. They're starting to be fussy and cranky, and other signs and symptoms are starting to show up. You may want to percuss the cranium and see if maybe you get this sound. That would be one of the biggest things you might find out of this. So hopefully, if they're starting to show signs and symptoms, that the parents have already taken them to the pediatrician or they've had an evaluation, but just in case they haven't, percussion of the cranium could help diagnose hydrocephalus. One of the things to also consider with this sign is that if the fontanelles are still open, you're going to hear this. So it's not abnormal until after the fontanelles have closed. I'm not going to spend a lot of time on this slide. You've got all the information in your notes about it, but these are just some common scalp and hair issues that you might come across in your practice. After we evaluate the head, the skin would be the next thing you want to look at. Most of this is just going to be general inspection. Do they have any rashes, discoloration, bruising? How's the temperature when you palpate? Are they cold? Are they blue? Are they blotchy? Those might be some things to document on with the skin in that examination. Some terms I do want you to understand are what we got under the newborn section there. So vernix is the white covering that is on babies after they're born. So you're likely not going to see that in your practice, but I do want you to be familiar with what that term is. So that is vernix. One of the things I do want to discuss is the importance of vernix. And so one of the nice things and things that you may come across in practice is delay of bath. And I'm going to post some more information on that in your supplemental information on the module, but it does have a lot of great immune properties. It acts as a moisturizer, and it also helps to regulate babies' vitals after they're born. So just trying to not get rid of that right away is going to be important for baby and mom too. Lanugo is that soft peach fuzz hair that babies have. So some babies might have it on their face, or their ears is a really common spot, or even along their back. It's not permanent. It usually falls out, but that's what the fancy term is for that fine fuzzy hair that's on the babies. And then with jaundice, we're going to get into jaundice in the unit 2, but this would be, yellowing of the sclera, glowing skin, looks like they've been to the beach already, and this could be a sign of jaundice. So we're going to get into more jaundice discussion later on. And then melia are if you look in the bottom left picture there, you can see these little white little bumps on baby's nose. No concern there, all normal. These often go away, so parents shouldn't be scratching at them or poking at them or anything like that. The eyes can be pretty difficult to examine in infants and young kids. So I'm going to give you just a few things for you to really focus on with your examination. So the first part is going to be inspection. You're going to look at the eyes. Are they symmetrical? Are the eyelids opening? Is there any discharge present? Pupil symmetry? You're going to look at all of those things before you even get started. One of the things I do want to point out to you is visual acuity. Visual acuity is not well developed early on. At birth, visual acuity of an infant is about 2400. So when you're, taking care of a newborn or a young infant, if you're standing across your treatment room or far away from that baby, they're probably not going to be able to see you. You're going to be a blob to them. So when you're evaluating that newborn or that small infant, you want to be fairly close. So within maybe a foot or so 12 to 18 inches would be a good place to be. If you're any further than that, they might get a little scared because they can't really see what you are or who you are. And so if you get a little bit closer to them, it might comfort them down. So yeah, visual acuity is really poor. By age 7, you're going to see that normalized to about 20/20. So in order to check this, there's a few different ways to check this. So in an infant, you're going to use what we call the central fixation test. And younger than 6 months, this is going to be hard to do, but after 6 months, you can start this test. So what you're going to do is you're going to cover one of the infant's eyes, and you're going to hold some kind of object. I have like a colored wand, or you can hold a pen or something bright that they might look at, about a foot in front of the baby. So you're going to cover one eye, hold that object out in front about 12 inches. What the baby's going to do is they're going to focus on your object, and that is normal. Okay, then you're going to switch eyes and check. Now, if there was some kind of abnormality, what you will see is that the baby will try to move your covering hand away from their good eye to be able to see it, or they're just not going to look at it, at the object. So those would be some things to look at when you're evaluating a young infant. When they get to be a toddler, let's say 3 to 4 years of age, you're going to use a tumbling E-chart, and I've got a slide to show you what that looks like. With this, you're going to set them up the same distance as you do an adult on a Snellen eye chart. So you can either have your 10-foot chart or your 20-foot chart, and it'll read the same. But what you'll instruct your patient to do is they're going to cover one eye just like you do the Snellen eye chart, and you're going to have them tell you which direction the E is pointing, the open E is pointing to. So they can either tell you up, down, left, or right, or just point their finger whichever direction the legs of the E are pointing to. And then after they can start reading letters and recognizing that, then you can use the Snellen eye chart for visual acuity. One of the things I also want to talk about is eye development in general. So from weeks 2 to 4 in a baby, you're not going to see them really tracking objects or anything. They're really going to fixate on things. So they're going to really like stare off at lights. It's going to look like they're not really focusing or really seeing much at that point, but that's fairly normal. So from 2 to 4 weeks, they're going to really fixate on objects. From about 5 to 6 weeks is when you'll actually start to see them tracking maybe mom or dad or a toy or something in front of them. So if you're evaluating a newborn, you're probably not going to do a lot of the H pattern, position of gaze type testing because they're not going to track anyway. So you really got to look at how old the baby is and how you're going to evaluate. So 5 to 6 weeks is visual tracking. And about 3 months is where you're going to see the eyes actually converge. This is a really fun time to see because it's kind of when babies realize that their hands are attached to them. So this is when you're going to see developmentally that they start to take their hands and put things in their mouth, because they're starting to recognize that they've got that movement and that's part of them. So you might see that they'll start to look at their eye or their hands, and their eyes might go cross-eyed as they start to really look at that. So that's another common time frame where you'll see some changes in eye development. So, sight develops over time, but their eyes are fine. Their brain just hasn't had time to process all of that. So this is one of the areas that does take some time to develop, and it's not fully developed right at birth. So their eye structure is fine. It's just that their brain is not processing what they're seeing yet. So that takes a little bit of time. And then by about 5 months is where they'll start to see color and more depth, so more 3D type vision at that point. This is the tumbling E chart that I just reviewed in the last slide to check for visual acuity in our toddler kids. A few other things to consider with the eye exam is palpation. I'll tell you that I don't often do palpation unless I feel that there's some kind of concern with the eyes. It's not a comfortable procedure to have done to you, and some kids get a little scared with it. So I don't often include it in my eye exam unless it's necessary. So, if you were to do that just to see if there's any extra pressure in the eyes, you would just take your index and middle finger over the eye and just apply a little pressure. Baby and child's going to get very uncomfortable with that. But again, not a common exam procedure that you're going to do on day to day. It's going to be one of those things that you kind of pull out if you clinically think it needs to be evaluated. The ophthalmoscope is going to be a difficult exam for you to do on a kid. As far as patient positioning, one of the best ways to position the child for this is have them on the parent lap. Parent is going to wrap one arm around the child's arms, kind of to restrain them, and the other hand is going to be over their forehead. So they're calm in the parent's lap, but they're also kind of restrained so you can get in there and peek really easy. With this, do not ever pry open a child's eyes with that. If they're crying, you may have to just come back to the eye exam after they relax a little bit. But with the ophthalmoscope exam, the main thing we're looking at is the red light reflex. We're going to look for direct and indirect pupillary reflexes. If you can get in there to look at internal structures, great. If you can't, make sure their eyes are dilating and constricting like they should, and that red light reflex is there. Those are going to be the key things to really pull out of that ophthalmoscope exam. You're also going to run through your H pattern of gaze in our older kids and infants that can track objects. So we kind of already talked about that. So you'll want to make sure that they are moving through and that their eyes are moving like they should. This slide is just to refresh your memory on what the red light reflex looks like. So normal, you should see the red light in both eyes, equal, bilateral. Abnormal, you might see that there's no reflex at all. It might be in one eye and not the other. It might be gone in both. You might see a white reflex. These would be abnormal findings, and this would indicate a need for referral. If the child does have that absence of that red light reflex, it can mean a lot of different things. It could be a cataract, glaucoma, retinoblastoma. So there could be a variety of different things. And so please refer them out if you ever see an abnormality with this exam. You may also see some cases of strabismus in your office as well. Newborn and young infants may have some slight deviation, which can be normal. So, be careful with this one. It's still one of those things I point out to a parent, and I still want their pediatrician to be watching. But anything over 4 to 6 months of deviation is a referral. It's not normal at that point. So again, just like I said in the red light reflex, any abnormalities refer. There's no reason why, if you do find something like this, just tell a parent, hey, I'd like your pediatrician to check this out, make sure there's nothing else going on. Or maybe there is something else if you're looking at they're not making eye contact, there's other abnormalities, maybe they do need a further referral. So, take the eye exam pretty seriously, but understand that in newborns and young infants, there might be some slight deviation that's normal. Next, we're going to go over the nose. This one's really going to come down to inspection, palpation, kind of looking up the nose a little bit. You're going to look for deformities, any discharge. If there is discharge, what side is it coming out, how much, what color. So that would be important to note on your examination. Also, if they are having a lot of discharge coming from their nose, have they been sick recently? Do they have allergies? Are they teething? Have they been to daycare? I mean, there's a lot of other questions you might want to ask with that. If you get a green, foul-smelling discharge coming from one side and there's a lot of pain on palpation of that side, it may be an indication that there's a foreign object somewhere in the nose. Kids are known to put things in their nose and their ears, so if that's the case and you're starting to see some of this on your examination, that might be something that's going on with the child. Don't ever remove anything that's stuck in the nose or the ear. Refer them out for that. You are not to remove those objects as a chiropractor. Other things to note with the nose exam is, looking at how the baby's breathing. We already went over respiration rate and the effort with that, but we talked about the flaring nostril often showing signs of respiratory distress, so pay attention to that. When we also look up the nose, we're going to look to see what the mucosa looks like. The color can tell us a little bit about what's going on with the child as well. And then something to note as far as sinus development. Your maxillary and ethmoid are developed in infancy, so those are present right at birth, but your frontal sinuses actually don't develop until about age 5. So I just want you to be aware of some of the anatomy changes that happen during this pediatric time. The ear exam is going to be a really common physical exam that you will perform more of in your office. Kids are going to come with ear infections. It's a really common thing for kids to have. And so you're going to really need to get comfortable with the ear examination. So we're going to walk through that step by step here. The first step is going to be inspection. We have the 4 Ds of inspection. This is discharge, discoloration, deformity, and displacement. Discharge from the ear can be a few different things. It could be just an extra amount of wax. It could be discharge from some type of ear infection, whether that be an otitis externa, which is your swimmer's ear, or an acute otitis media, which is your middle ear infection. So when we're looking at discharge, again, we want to know if it's coming out one side or both, what color is it, how much. Most of the time it's going to be that wax discharge, especially if you're just looking at the ear and you haven't really looked in the ear. If anything's coming out, most of the time it's just an extra amount of wax. Sometimes you'll see based off color of discharge that can mean a few different things. So your ear infection might look kind of like a milky white or yellow discharge. If there's been any kind of trauma like a tympanic membrane rupture, or maybe they've shoved a Q-tip too far, you might see kind of a cloudy discharge or even some blood in that. The swimmer's ear is kind of a watery yellow or crusty discharge, and then a head injury would be clear or bloody discharge. So it's really important that you note the color of the discharge coming out of the ear. I already talked about the rupture of the tympanic membrane, but then just as we talked in the nose exam, foreign objects, foreign bodies in the ear can also cause that foul-smelling greenish discharge. So again, they're going to have pain with this. They might have trouble hearing out of that ear. But if you do suspect that, please refer them out. The next D in the 4 Ds of inspection is discoloration. This one you're not going to see a lot of, hopefully, in practice, but one of the things you can look for is if there's any kind of bruising or swelling or any color changes around the ear. What you're seeing in this picture in this slide is what they call a battle sign. This is often associated with some kind of trauma, usually some kind of temporal bone fracture, which is common with child abuse, could be from an auto or a bike accident. With this same sign, you might see some bloody discharge that comes from this. But if you see anything that looks like this picture or has a battle sign or bruising over that mastoid area, that is a sign of some kind of trauma, and it needs to be referred and considered an emergency. When we're inspecting the ear, we also need to look for deformities of the ear. Common ones that you're going to see that I can give to you, or if you've ever seen a wrestler or known somebody that's been in sports, cauliflower ear is a common one. So because of physical trauma or anything like that, they've developed some kind of outer deformity of their ear. Usually there's no hearing issue with that, but that would be an example of some kind of deformity. On babies that may have some kind of congenital deformity, those are when we need to consider there's a possibility of some kind of issue with hearing. So I often look at if it's a congenital deformity in the outer ear, I always wonder, is there an inner ear, middle ear deformity going on as well? So I always like to have their hearing evaluated by an audiologist if I am seeing some of those congenital anomalies with the ear, because many times you're going to see some hearing issues with that. I'm not going to say every time, but a lot of times you're going to see that they're going to have some inner ear issues as well. And then the last D of inspection would be displacement. This would be where one of the ears maybe is pushed forward for some reason. You might see this with mastoiditis, which is there's some swelling over the mastoid process after an ear infection. It's a more significant ear infection of that case, and we're going to talk more about mastoiditis later, but that could cause some swelling and pushing that ear forward. If they've got cellulitis, maybe an insect bite with some edema there, those may push the ear forward as well. So those would be the final 2 Ds of inspection. After inspection of the ears, we're going to palpate. And so I always like to palpate the ears before I ever do any otoscope exam or anything else. I've got a diagram of kind of the structures of the outer ear here for you on this slide, just so you can remember. As I kind of take my hand and I go around the ear and I just kind of palpate and kind of give it a little tug to make sure there's no pain or discomfort with that before I put the otoscope in. Also with palpation, we're going to palpate the lymph nodes. So it's common that, if they've got an ear infection or maybe even had an ear infection a week or 2 ago, that they still have some swollen lymph nodes. So we want to just take a quick peek and feel at the lymph nodes around the ears. We're going to go up around the ears, along the jaw, down the anterior and posterior chain of the neck. So we want to make sure that we're checking those out when we evaluate the ears as well. The hearing assessment is going to depend on the age of your child. So with an infant and toddler, we could use a startle response or an acoustic blink response, which I'll demonstrate when we talk about cranial nerve and primitive reflexes. But that would be something that you can do up to age 13 months or so. After about a year to 3 years, what we can use is like a toy or some sort. So I often use my keys. So I'll have the baby lay down or even seated by a parent, and I'm going to shake my keys out of the child's visual field. And what they should do is turn towards that sound. So if they hear me rattling a toy or my keys on their left side, they're going to turn towards that sound. So that would be a way to do that. If they're toddler age, you can also whisper in their ear and have you repeat words that they say. You can let them listen to a watch if they can hear the ticking of your watch. That's another way. When they get to school age, you can do your Weber and Renee test with your tuning fork. Remember that you're going to use the 512 tuning fork for hearing assessment. In the otoscope exam, you'll see in my demonstration video how I hold my otoscope, and I'm not going to spend a lot of time in this lecture going over that, but I do want you to watch the demonstration video that I have. I am going to show you how I position the otoscope to be safe for a child. One of the things you do want to make sure is that you're using the proper speculum or the tip for your otoscope. They do make adult size and child size, and you want to make sure that you're using a child or pediatric tip for that. The otoscope exam can be very traumatizing to a child, whether that be because they've been to the doctor's office a lot of times, they've got recurrent ear infections. It can scare them. So you may have to let them examine your teddy bear. Often I'll have the child do an otoscope exam on my adjustable bear, or even myself or whatever. Let them get comfortable with your tools, and then they'll let you perform that. You can play games, you can play hide and seek, we can look for monsters or bugs in their ears, whatever might interest them at that point. So you may have to be a little playful during this. So the main thing with the otoscope exam is we're going to have our otoscope upside down with our finger against the head, protecting the depth of the speculum. What we're looking for when we do this is we're going to traction back and down on kids. And then as we look, what we're going to look for is what the tympanic membrane looks like. If there's a perforation in there, what kind of discharge is in there. If there's wax, of course we want to know what color is it, how much, is it so impacted that you can't visualize the tympanic membrane. These are things that you're going to want to note on your exam. You've probably seen this picture before, but I like the side-to-side comparison to show you an infant, young child versus an adult eustachian tube. And one of the reasons why we see a lot more ear infections in kids is because of structural changes. We've got a more narrow, more horizontal, shorter eustachian tube in a child versus an adult. So you can see where draining of that eustachian tube is a lot more efficient in our adult patients than it is our kids. So again, a reason why we see more issues with ear infections in babies and young kids. The next couple slides are just going to go through some otoscope tympanic membrane evaluation here. And so I want you to see what a normal tympanic membrane looks like. You're going to see a nice translucent gray appearance. There's no discharge, there's no redness. You can see the nice cone of light. And so I just want you to see what a normal tympanic membrane is going to look like. This might be what an acute otitis media looks like. So this is a middle ear infection, which is really, really common in kids. You're going to see that the tympanic membrane just looks really, really mean. Looks like it's about ready to explode here. So it's bulging, it's red. This child's going to be a lot of discomfort as you do the otoscope exam. So you're going to have to get really good about being quick and efficient and being able to see what's in there. You also might see some discharge that comes with this as well. This would be an acute otitis media with effusion. So often what will happen is the child will have one of those acute otitis media infections, and then after that's kind of healed, they'll get some fluid behind their eardrum. And so that's what you're seeing in this picture. So otitis media with effusion is really just fluid behind the ear. So when you look in the ear, you're going to see these little bubbles with your evaluation, which it's really neat when you see it. But that's what it looks like. So the canal's not red, it's not bulging. It can be the tympanic membrane can be a little retracted in these cases, but for the most part, you're just going to see maybe some bubbles in your examination. And just for fun, a foreign body. So there's a little grasshopper that's in this kid's ear. Now we're going to move down into the mouth and the oral cavity. So the biggest thing with looking at the mouth, we're going to do some inspection first. So you're going to look for color of the lips. We're going to look for symmetry. Are the corners drooping on each side of the mouth? What's going on with that? If they're old enough, you can have them smile to see if that looks symmetrical or not. With the mouth exam, this can be a really tricky examination to do on small kids and infants. So just a few tricks for you. You may also have to play a game with this one, just kind of like what we did with the otoscope exam. We may have to play around with this one. So if you've got your otoscope light or your pen light out, you can talk about lighting up your teeth or stick out your tongue. Let's play some games with that. So you may have to trick them into getting them to open their mouth. Often they don't care they'll stick out their tongue for you. That's often a fun game that you can play to get them to do that. But just a few tricks to help you get through this oral cavity exam is if you're using a tongue depressor, wet the tip of it. It actually makes it taste a little bit better to the kids, so that might help as well. When you're getting the baby to open their mouth, if you are evaluating an infant and you're having trouble getting them to open their mouth to look in, one of the things that you can do if you're holding the baby or the parent is you can have them just slightly tip the baby's head down and the baby's mouth should open. Another not so nice way to get baby to open their mouth is you can pinch their nostrils. in order to breathe, they're going to open their mouth. So that's not my first go-to on getting baby to open their mouth, but it is a way that you can do that. Once the baby's mouth is open, we can go in and look at the tongue. We can assess the strength of the suck response. And so with this, we are going to insert a clean finger, or you can glove up at this point. You're going to slowly insert your finger into their mouth. You're going to feel the palate. So the first thing you're going to do is actually assess the strength of the suck. So it should have a nice suck. You should feel that on your finger. While you're in there, you're going to just lightly assess the palate, your soft and hard palate. And then to do the gag reflex as you're in there, just lightly slide your finger back just a teeny tiny bit and you'll elicit that gag reflex for them. If they have just eaten, just be aware that they may spit up on you. When we get into look in the mouth, we're going to look at the tongue for the size, the shape, the color, what it kind of looks like. I've got some pictures on another slide to kind of walk you through that. But you know, you could have a coated tongue, which can be a variety of different things. Could be dehydration, yeast infection. You know, a smooth tongue might be caused by some kind of allergy, dry mouth. Maybe the child's burnt their tongue on something hot. You could have a smooth tongue with that. Your raspberry tongue may be part of a scarlet fever issue. And then your geographic tongue is just a normal finding, just kind of all those bumps and cracks and different things. So nothing abnormal there. While we're in there, we're also going to look at the tonsils in the throat. So with tonsils, one of the things you can look at is the size. I don't know if you guys have learned how to assess the size of a tonsil, but as you're looking at them, it's kind of graded on a scale of 1 to 4. So a 1+ would just mean that the tonsils are visual, that you can see them. A 2+ would be that the tonsils are sitting about halfway between the uvula and the pillars. And then a 3+ would be that they're almost touching, and then 4+ would be that they're touching. So the 3 and the 4+ might be enough to, you know, dig a little deeper. Do they snore at night? Are they having trouble breathing? Are they mouth breathers? If that's the case, maybe they're sick all the time, you may want to refer them out to an ENT to have them evaluated. So just to kind of keep that in mind as far as how to grade and look at size of tonsils with that. You can also look to see if they've got any cobblestoning that's in their throat, which is really common with like allergies and that postnasal drip kind of issue. You know, as far as getting kids to open their mouth, you could, you know, play a game as far as like pant like a puppy dog, say ah. You know, there's a lot of different things that you can do to get them to do that. So just kind of be playful as you're going through this, be really calm and reassuring to them, and don't be real forceful when you're trying to do a lot of these exam procedures. These are just some of the images of the tongue and the throat that I was just referencing in the last slide. So you can see the smooth tongue, the strawberry tongue in the cases of the scarlet fever issue, and then the cobblestone in the back of the throat, which could indicate a chronic allergy of some sort. Just a few other things to look at while you're in the mouth is we're going to look at the teeth. We're going to make sure that their teeth are coming in fine, that there's no issues with their gums. We're going to make sure that we're not seeing any signs of grinding or discoloration in the teeth. The American Dental Association recommends that children see their dentist for the first time at either 12 months or right after their first baby tooth comes in. So that might be something that we want to recommend to our parents if they haven't already done that. Other things that you might come across is infant thrush. We're going to talk more about this when we get into breastfeeding issues later on, but this would be where they have kind of a white plaque on their tongue and inside of their mouth that doesn't wipe off or scrape off. You know, with newborn babies, often you'll see a white tongue after maybe they've eaten breast milk or formula. That wipes off and comes off. With thrush, it's not going to budge. Baby's going to be real irritable. Mom maybe have some nipple pain and discomfort while she's nursing her baby. So we're going to go over more on thrush when we talk about breastfeeding issues later. And then something else I want to point out to you is the Koplik spot, which are these little small bluish white dots in the mouth, usually on the cheek, often in the lower first and second molar area of the mouth. These are found usually about 2 to 3 days before the measles rash appears. So it's a viral infection for measles. What it'll look like, more specifically, if they do have these, it looks like a little grain of salt with a little bit of red behind it. But this is often a precursor to the rash that they get with measles. So this would be something to think about if you suspect that condition. And then lastly, we're going to evaluate the neck. So we already talked about palpating the lymph nodes when we talked about the ear exam. In the case of the neck, again, this is all going to be inspection. We're going to make sure that there's no abnormalities there. And also we're going to palpate the thyroid and then have the child swallow to feel the movement of that.